This year, we spot a light on one of the challenging cancer in gynae health, mainly focusing on the cervical cancer and endometrial cancer. So I have Dr. Rubina Farouk. She is the head of Gynae Oncology Unit, 2 in Services Hospital. She is the pioneer in developing gynae oncological setup in public sector, and she is involved in conducting the multidisciplinary meetings along with the referral of the oncology patients to the other centers. So thank you so much, Dr. Rubina, for joining in. So today, our first speaker is Dr. Rana Irfan Mahmood. Everyone is aware of his name. He has more than 20 years experience in the oncology, and he has actually played a great role in developing image-guided brachytherapy, not only in Colchester, Ipswich, the NHS hospital, but also extend his services in the Dubai and Middle East as well. He's currently working and establishing the image-guided radiotherapy units along with the intraoperative radiotherapy in Dubai hospitals, and he is also involved in the patient quality. So today he's going to present his talk on the hybrid image-adapted radiotherapy in cervical cancer. So welcome and thank you for coming.
Thank you very much. Yeah, it's a pleasure to be here, and thank you very much for the organizers to invite me for this. And die-hard fans of gynecological oncology, waking up very early and rushing through the traffic, be here at 8:30. So we only have less than 20 minutes to go through what we have been watching the evolution for last maybe at least 20 years. So it is nearly 20 years now when we stopped doing the point A based brachytherapy. So the people who do not practice brachytherapy in cervix cancer, the cervix cancer radiotherapy requires external radiation, but then boost with brachytherapy to the primary tumor. And that boost, the purpose of that boost is to give highest possible dose to the tumor, because we know that you need very high dose, which can't give with external radiation, but at the same time trying to avoid much dose going into the bladder on the front and the rectum on the back and the colon or something hanging there. So historically, we had been prescribing blindly based on X-ray images, 2D images, loading the applicators which we placed into the cervix at an arbitrary point called point A, which is just 2 centimeters above and the lateral to the flange. That was just an arbitrary point. Everybody agreed over 50 years, and that is Manchester technique and Paris technique or whatever that is. But then imaging became quite involved in brachytherapy, in general in oncology, but specifically brachytherapy. So we started looking at the applicators not sitting in the right place even, and then we are still burning everything else. So this led to image-based brachytherapy. So I just split the learning points just briefly. I think we don't have time to go through everything in detail, but couple of slides to show that why brachytherapy is still important in SBRT, because this had been something which had been discussed over last 10 years or so, but a few years ago, plenty of data published, presented, has closed this topic that SBRT is not as good as brachytherapy. Brachytherapy is must. Point A to sculpted pair, which I call to squash the pair. I will show you. Then the series of EMBRACE trials led to the benchmark of the brachytherapy practice which we have today. And I was happened to be principal investigator for EMBRACE 2, so I will talk from that experience as well. And the final first overall result was presented in ESTRO this year by Richard Porter. So this is just a disclosure that I'm not biased or anything other than just that EMBRACE I was in principal investigator. So just a couple of slides as I promised, that why brachytherapy is still important. This is from the Society of Gynaecological Oncology and ABS, where it is very disappointing to see that in American practice, only less than half of the patients received the standard of care. And the standard of care by definition requires external radiation followed by full brachytherapy, and only less than half. Exploration of the reasons were basically that there was not much like academic centers treating cervix cancer patients. Many centers only had less than 5 patients in a year. They did not develop techniques, they didn't develop technology or experience, and that was the main reason. So only 8%, only 8% of US facilities treated average more than 3 patients per year. Okay, that was the reason. So pooling on to the best case practice, although in Pakistan we don't have that issue because number of cases are too high. Trends in utilization in cervix cancer have been declining in the United States, and this is the data published in multiple forums showing the same thing, that brachy versus no brachy makes a huge difference. So that chapter is closed. So I will not spend even a single second on that one. Why did we move from point A to the sculpted pair? Because this is a study which was showing that it's a very nice group in Aarhus in Denmark, where they did the hugely experienced principal investigator of Embrace as well, Carrie. So they did this study where they did a standard loading, which had been practiced all number of years in Aarhus, and then they did the image guided, to see what is the difference. What is the most important part is represented in this image here, and that will come into the subsequent slides as well when we look at what we learned from retro embrace trial. What we learned is that you need to give a high dose, of course, for radiotherapy, but if the volume of the tumor is small, you can give very high dose. You don't need to give that high dose if you are giving it to point A. But if the tumor is small, if your tumor is large, the point A dose does not represent you are underdosing the thing. So this is what the study images are: standard loading versus the sculpted loading, and everybody who knows the image based will know how it works. This is the data just to show the same thing again, that standard dose or optimized dose. Standard dose were all over the place, very high dose to the small tumor, very low dose to the large tumor, exactly opposite to what you should be doing. But when you set a benchmark of 85 gray, image guidance bring more or less closer to that. We want to bring it further down, and we want to bring this further up. And similarly for the organs at risk, it is very obvious that you can sculpt it much, much better. I put the slides to this graphic here is just to show you that this is what we have learned. 2008, as I said, nearly 20 years ago, the idea of image-based brachytherapy started, and retro embrace and embrace started at the same time. Embrace 1 was given to those centers where they were not doing image-based brachytherapy, and they were trained, and there was no dose prescription requirements. They were just given an experience of image-based brachytherapy, and then there were those centers who were already practicing image-based brachytherapy. They were asked to submit data for retro embrace. Started at the same time, 1,400 patients, 800 patients. 2015 it closed, and it showed a lot of learning points which were carried forward onto the Embrace 2. Embrace 2 closed in 2021, nearly 1,500 patients, and the first overall result was presented in Embrace this year. So what we learned from retro embrace or Embrace 1 is that you need to give a high dose of radiation. Local control, if you look at the local control, you need to give at least 85 gray. Here it is the final summary, that if you give 85 or more gray, only then you can expect that 3 years local control will be more than 96% in smaller tumors and more than 91% in 30 cc. So that learning which we had from retro embrace and embrace protocols and data benchmarked 85 gray as the minimum acceptable dose, and we should be aiming for dose higher than that. The other thing what we learned from that is the institutions. Remember, retro embrace had institutions where they were already practicing brachytherapy, and then there were centers where they were not. So the data was pooled, and it was showed that the centers where they had a routine access of hybrid or interstitial brachytherapy, there was a 10% improvement in local control, and that was a huge thing. So we learned that 85 gray is minimum. We learned that interstitial brachytherapy combined with intracavitary leads to improved outcome. And we found that about 35 to 40% patients were getting interstitial brachytherapy in Embrace 1 and Embrace 2. So all this data led to the formation of Embrace 2 hypothesis and benchmark. And I will show you one in a second. Next slide. So here, this is again what we learned, that smaller the tumor, people are happy to give very high dose. Do they really need to? No. So we need to squash it down. People who are treating a very large tumor tend to not give that much high dose. Practically they can't, so we need to escalate the dose, and we need to de-escalate the dose. So in Embrace 2, we took this information into action, and we said 85 gray is the minimum, 95 gray is the maximum. Try not to give more than 95 gray, try not to give less than 85 gray, squeeze everybody inside this one, and then you can expect a very high local control. That's what Embrace study was made for. And now there is an Embrace low risk and high risk, where we want to de-escalate it further, and we'll escalate it higher. I will not talk about that one because it's still in the formation. So Embrace 2, we wanted to increase the use of interstitial brachytherapy. We learned that vaginal toxicity was not correlated to D2CC vagina or vaginal points. So we wanted to control the dose going to the vagina, because that causes serious sexual dysfunction, vaginal stenosis, and we want to control that. Or target contouring, OR contouring was supposed to be benchmarked in the study. So every center, every investigator was trained and tested. So elective nodal CTVs were adapted. We wanted to have simultaneous integrated boost. Everybody was supposed to give 45 gray in 25 fractions. In retro Embrace, it was allowed until 50 gray, and there was no difference to give 50 gray other than the higher toxicity. And that is just one slide to show you that what I just said, that IMRT was essential in Embrace 2. 45 and 25 was essential. So only focus on this side of the graph, which basically just shows you that V43 gray, which is a significant dose balloon, in Embrace 1, this was all over the place, very high volumes receiving V43 gray. But when you go to the IMRT Embrace 1 and then the Embrace 2, the volumes were smaller, hence the toxicity was smaller. This is, again, I will not spend much time because this is not this brachytherapy portion. However, just to show you that, just to highlight that IMRT is absolutely helpful in cervix cancer, because some people are still giving 3D boxes. So these are the 3D boxes and IMRTs in Embrace 1. Dose all over the place, conformity index you can see here. But in Embrace 2, this is what we get. When we follow a benchmark protocol with CTV, GTV, PTV drawings and use IMRT to squeeze the dose, this is what we get. Okay. So these are the aims I already highlighted. We want to give actually more than 90 gray to 95 gray, minimum 85 gray. And this is what I highlighted here, because everybody focused on bladder and rectum and sigmoid and bowels, but rectovaginal, in my opinion, is extremely important. So this is the quick summary of the result which was presented in the last Estro, and I will just highlight salient features. Remember, this is a European data, so you will expect that most patients will be T2 patients, FIGO stage 2 patients. Although my experience here is that most patients have locally advanced tumors. So this is just to highlight that even in what we can learn from this one to our practice. What we learn here is that even the smaller tumors required higher dose, number one. Number two, what we learned, because see, the GTV volume, initial volume was only 37 cc. And after radiotherapy, the residual GTV was only 5 cc, which is kind of, we don't see here. So this is what we learned, that even the smaller tumors require higher doses. The second learning point for me here, for our local practice in this part of the world, is that despite the fact that 85% patients in this study was T2, okay, they were not stage 3B or whatever, yet 74% patients had needles, okay, which is called interstitial brachytherapy. So this is a very, very important point, that to gain that dose, gain that outcome, we must consider if 85% of patient population having only T2 tumors, 74% had needle. In our practice, it should be nearly like 100%. Like every patient should have needles to increase the dose to the target and reduce the dose to the organs at risk. So the first one is for the external radiation, so I will skip. As I said before, that you can squeeze the PTV margins with image-guided radiotherapy. You're following the protocol-based treatment. Conformity index, your physicist should be able to recreate that, and these are the things. So increased use of IC and IS. Overall treatment time, median was 43 days. And that is another thing which I think we have to focus very hard in our logistically challenged population, that we must try to give radiotherapy and brachytherapy tag along immediately after each other. However, there is no need to give radiotherapy earlier on, because I will show you the benchmarks which came out more recently, that you should give at least 4 weeks of radiation before you bring in brachytherapy. I think we're running out of time, so I will start skipping to some slides. And this is just to summarize that from Embrace 1 to Embrace 2, simply benchmarking and controlling how people are treating it improved the outcome. Overall results are very encouraging, very helpful. These are the new benchmark studies. This is new standard of care. That's the final outcome of this study, that if anybody wants to audit their data, they must show that they can achieve these kind of 3 years, 5-year survivals and these kind of outcomes in terms of local control. So in comparison, a reduction in late toxicity, again, I don't have time to go through the whole details. The toxicity reduced, outcomes improved, and the final statement is that Embrace 2 protocol-driven benchmarked treatment one should aim to follow. Everybody need to download the Embrace 2 protocol and just try to replicate their practice to Embrace 2 protocol, and they will be all right, because that is now a proven benchmark and a new standard of care for locally advanced cervical cancer. All the trials in the future conducted will have radiotherapy built in as Embrace trial protocol. And this is just to kind of throw a kind of a contentious issue. I hope there is no medical oncologist here, because they don't like cross-trial comparison. But this is Embrace 2 data on this side. But then we have nowadays a lot of things happening with interlace trial, with neoadjuvant chemotherapy. We have a very expensive pembrolizumab Keynote A18 trial, although I can show you, if I have time, to a recent publication where American data shows that it is not cost effective. Cost per quali is very, very high. So anyway, the data matches very well with what is published with interlace-like cohort or in the Keynote 18 cohort. So this is where we kind of end the Embrace 2. What is the future? The future is, as I said before, that dose escalation and de-escalation. This is where we need to individualize treatment. And of course, in our part of the world, it's always going to be dose escalation. I don't think we are having a patient where we are going to go to dose de-escalation. So we'll need to focus on that one. And if there is an opportunity, I would say contact Richard Porter's team in Embrace and Embrace high-risk protocol. Enter your patients into that one. Practice in India is very much geared towards Embrace, and they have their main centers now, Embrace centers in India, and I don't understand why can't we do that, because we have so many patients and technology and experienced people, so why not? So this is the one thing, the audit quality, the research, reducing the toxicity, increasing the outcome. Applicator designs, ultrasound-based real-time work in progress. I think that's what's going to come. AI and biological optimization is real future, because you have now better and better functional imaging with novel tracers. Can you just dose escalate on certain parts? Predictive markers, imaging, all of that is required. I don't have time to go through the biology. The why D2CC of vagina is not important. Why we should be putting the dose onto the reference points as in Embrace 2. There is a plenty of data Anybody who wants to have that further discussion about vaginal toxicity, we can meet in the coffee area, because this is extremely important, because we treat the patients and then young girls, and they have to suffer for the rest of their life with vaginal stenosis, marriages break down, the family issues, all kind of stuff, and we are responsible to cause what we call survivorship issues. So the vaginal toxicity, vaginal stenosis, everything narrowing and closing down, we are responsible for that, so we should take care of that. And there's a plenty of data to guide you about it. This is directly from the Embrace 1 study, where what we learned, that there's no D2CC of vagina as like in bladder and rectum. You have to consider the vaginal reference length and the PIBS, which is the inferior point at the pubic symphysis. And this is all correlated to the vaginal toxicity. Again, these are the curves anybody wants to have. I will show them later. Final bit. This is the recent one, which I feel that every center practicing cervix cancer, radiotherapy, brachytherapy should download this one. These are the benchmarked quality indicators. Every radiotherapy department should have a quality indicator for their audits. Pick 2 or 3 points from this audit, which are like 16, 17 points, and show your data is compatible to this. And if not, then change it and re-audit it. So MDT, 95%. PET scan, more than 90%. Radiotherapy within 6 weeks, more than 90%. To clinical trials, upfront radiotherapy, patients are treated with brachy boost, more than 95%. Simultaneous boost, optimal target, 100%. Onboard imaging, more than 95%. Pelvic dose, 45 and 25, more than 95%. Lymph node boost, more than 95%, with simultaneous integrated boost, more than 90%. Chemotherapy use in more than 95%. Image guided adaptive brachytherapy, 100%. Okay, 100%. So combined use, more than 60%. Although in Embrace 1, as I showed you, 74%, even with a smaller tumor. So this is at least 60%. We should be aiming the target to like 70 to 80%. So this is what I was saying. Do not start brachytherapy before you have given at least 36 gray of radiation to achieve the maximum geometrical benefit. Overall treatment time should not exceed more than 50 days. I think this is the last slide. So brachytherapy treatment, whenever we give, should meet this table. So very, very easy audit. So whenever you do brachytherapy, you collect your data and match this with the table and see why you're not matching it, if you're not matching it. And then number of patients treated, this is where I don't think we have any problem, because the number of patients treated should be more than 20, a minimum more than 10. As I told you before, that only 8% of US centers were treating more than 3 patients per year. So they shouldn't be treating, they should be pooling the patients into other centers and increase the numbers. So these are the benchmarks which we all should aim for. I knew that.
Thank you, Dr. Irfan, for a wonderful talk. Definitely we'll be having more discussion at coffee table, and we'll take the question at the end. Thank you so much.
Okay, thank you.
Years of teacher, Professor Farooq Ismail is here. Assalamu alaikum, all colleagues. It's my great pleasure to welcome you to this session focused on advancing our understanding of endometrial cancer. As we continue to move toward more precise and personalized approaches in oncology, Figure 23 guideline has become a very important tool in guiding us about the diagnosis, treatment, and management of endometrial cancer. Today, we are honored to have with us Dr. Azmina Tajuddin, who is a renowned medical oncologist. Currently, she is working as oncologist at Aga Khan University Hospital, Karachi. She will walk us through the new genetic endometrial staging for endometrial cancer.
So we have Dr. Azmina as a virtual talk.
Bismillahirrahmanirrahim and Assalamu alaikum. Greetings to everyone. It's a pleasure to be part of this symposium and to share with you the changing molecular landscape of endometrial cancer and its impact on our current clinical practice. These are my disclosures. The aim of this presentation today is to enhance the knowledge of the evidence supporting modern treatment approaches of patients with endometrial cancer, integrate the latest options into personalized care plans, taking into consideration the guidelines, the biomarkers, and the clinical evidence to back it, and develop the skills to collaborate with multidisciplinary strategies to escalate and de-escalate treatment. Endometrial cancer is the second most common female genital tract cancer after cancer of the cervix, and there is a crisis in the Western countries with the increase in the incidence and the mortality of endometrial cancer, which is attributed to the lifestyle, obesity, diabetes, and the whole metabolic syndrome epidemic. This calls out for better prevalence measures, preventive measures, earlier diagnosis, and more effective treatment. And this is also attributed to a growing population, aging population in our part of the world also. When we look at the burden of cancer in Pakistan, this is the cancer registry from Punjab, and it shows that breast cancer is the most common cancer, and endometrial cancer is the 8th leading cause of cancer in women in Pakistan. Starting from the basics, the most common histology we encounter is the endometrioid with the different grades, and the rest are non-endometrioid aggressive histologies comprising of carcinosarcomas, clear cell carcinomas, and serous carcinoma. The Buchmann classification was first introduced in 1983 with a simplistic clinical pathological view of the endometrial cancers into two groups, with the type 1 being the estrogen-driven associated with obesity, a good histopathology and prognosis, and the type 2, which comprises about 20 to 30% of the cases, a non-estrogenic aggressive histology and have poor prognosis. Now, things have changed since then. In 2013, the TCGA, the Trans Cancer Genomic Atlas, provided us with the molecular subtyping of the endometrial cancers into 4 different types. And this provides a very reliable and predictive classification for treatment, and also provides the basis for the specific treatment strategies. So instead of the 2 groups that we were used to seeing in the Buchmann classification, we have the 4 groups now, and the Pol E mutated patients, which comprise about 2 to 7% of all, the MSI high hypermutated, which is 1/3 of the patients, another 40% are the no specific molecular type, and the serous-like, which have the high P53 mutation. The Pol E is the one which is associated with the best prognosis, and the serous is with the most aggressive histology and the worst prognosis, whereas these 2 types have the intermediary prognosis. Now, this colorful wheel of classification shows the distribution of the different molecular types and the corresponding histologies that we see with it. And we look at the progression-free survival on these patients. Based on this, we see that the Pol E has the best outcome, best PFS, and the hypermutated, the copy number high patients with the serous histology have the worst prognosis, and the intermediate prognosis for the mismatch repair deficient and the no specific molecular type. Now, how can we classify our patients in our clinics? Because the classification, the molecular classification is a genomic classification, requires NGS. We can use surrogate testing as it was proposed by the PROMISE algorithm, which stands for the Proactive Molecular Risk Classification of Endometrial Cancer. Here we use histopathology to identify patients who have the mismatch repair proteins. The lack of the mismatch repair proteins designates them to a DMMR entity. The presence of the P53 mutation designates them to a copy number high type, the TP53 wild type to the copy number low type. So these are all surrogates based on immunohistochemistry to identify the different genomic types that we saw earlier. But one thing that we cannot do in our routine laboratory is the Pol E mutated. For these patients, we need the genomic sequencing. Now, the understanding of this molecular classification testing was incorporated by the WHO, and earlier we were used to seeing the different risk groups divided into low, intermediate, high, and the advanced based on the anatomical staging of these patients. Now, when we have the molecular classification available with us now, which was modified by the WHO in 2022, we can see that there is a risk migration. So patients who were initially deemed to be low risk, anytime they have a P53 mutation, they will move into the high risk category. Anytime a patient comes with stage 1 to 3 disease, and whether they are low risk or high risk, if they end up having a POLE mutation, they become a low risk category. So this is how we will be able to migrate the stages from low to a high risk based on these molecular classification. Now, there was a lacuna in the staging of endometrial cancer, with anatomical staging being used till before 2023. So we were used to the 2009 classification, and a lot of trials that we're going to look at also use the same 2009 classification. The new 2023 classification aims to fulfill this gap by incorporating the histology, grade, myometrial invasion, LVSI, and if we incorporate the molecular classification with it, we are able to refine our treatment strategies. After undergoing optimal therapy, one assesses the benefit of adjuvant therapy in these individuals who may be potentially cured. And we have been assigning these patients to low risk or high risk or low intermediate or high intermediate risk based on these anatomical staging. And how we have done this is based on these anatomical staging, we have assigned these patients starting from 1997 to the PORTEC-1 trial, where patients were given for the high intermediate risk, were given external beam radiation and was found to be better for local control. Then we moved to, in the PORTEC-2 trial, we moved to patients who had a low risk disease, low intermediate risk disease, where vaginal therapy was deemed to be sufficient. And then we had layering on top of that and a more generalized address of stage 1 to stage 3 based on the histopathology and the grade to chemotherapy and radiation versus radiation therapy. And then in the later trials, we have moved to chemotherapy alone. So if we use the paradigm of PORTEC-3 to understand the benefit of chemoradiation versus radiation alone and its interpretation with the new molecular markers, one has to look back to 2013 when this PORTEC trial was first read out. And it applied the 2001 staging criteria. So in this patients who were treatment naive post-surgery, who had stage 1 with a high-grade disease or had lymphovascular invasion, or stage 2 and 3 disease, or they have stage 1 to 3 disease regardless, if they had an aggressive histology, were recruited to this trial, and they were randomized to a cohort of radiation versus a cohort of radiation and concurrent chemotherapy followed by chemotherapy alone for 4 cycles. The primary outcome was the overall survival and the progression-free survival in these patients. When we look at the 10-year follow-up on the outcome of the PORTEC trial, then we see there is an improvement in the PFS as well as in the ORS, overall survival, with a hazard ratio of 0.73 and 7.4. When we look at the 10-year follow-up on the outcome, we again see that the area covering the event-free survival is better in the patients with the chemotherapy and radiation therapy arm. The question is, can we apply molecular analysis on these patients and find out who are these patients who are going to benefit from this? So a retrospective molecular analysis of 500 patients in the PORTEC trial was done. Patients who had the POLE mutations were found to do the best, and regardless of what treatment they had, so they did not really benefit from additional therapy, thus arriving to the conclusion that perhaps we do not need any adjuvant treatment in these patients, regardless of the stage that they come from, which is stage 1 to 3 in the adjuvant. Now, the patients who had the P53 mutations, these were the patients who benefit from chemotherapy and radiation, and perhaps these are the aggressive histologies and where more can be done to improve the outcomes and move the graph up. In the mismatched repair deficient, there was equal response whether you give them chemoradiation or you give them a radiation alone. And because these are immune-driven tumors, maybe it's better to give them an adjuvant IO therapy rather than chemotherapy. The ones who are the non-specific, no specific molecular type, these are the ones where chemotherapy benefits, but we're going to understand more and learn more, because even within this type, there are subtypes who are going to benefit for hormonal therapy. So the conclusion based on the molecular analysis of the PORTEC was that the POLE mutation does not relapse regardless of the treatment. So perhaps no treatment is required. P53 has the worst prognosis and they have the greatest benefit from the chemotherapy. The MSI high and the non-specific molecular profile have the intermediate and but a little better benefit from adjuvant chemotherapy. So addressing this situation, a study was carried out specifically in patients who have mismatched repair deficient with intermediate prognosis by leveraging on the immunotherapy with chemotherapy in the adjuvant setting to see what was the outcome in these patients. The ENGOT B21 addressed the specific issue in about 1,000 patients, randomized them to chemo plus pembro versus chemo alone. About 27% of the patients also had radiation therapy, and they looked at the outcome of disease-free survival and overall survival. The interim analysis of the disease-free survival in patients who had pembro along with adjuvant chemotherapy with or without radiation saw that when you add immunotherapy to chemotherapy, you're improving the outcome of these patients in the adjuvant setting. Now, this is based on the principle that patients will benefit more if classified according to the molecular subtypes and be tested in the randomized fashion to establish which arm, the control arm or the experimental arm, is going to do better. This rainbow trial is aimed to answer this question of what is the impact of tailored approach on the outcome in our patients. Can we further refine the adjuvant therapy based on the cell-free DNA? And there has been an increasing interest in the use of cell-free DNA to predict the outcome of these patients, to have a prognosis and how these patients are doing, and be able to escalate or de-escalate treatment. Although in endometrial cancers, this has lagged behind and has not been addressed to the same intensity such as colorectal, but it is gaining traction. In a small study of 100 patients carried out by Susanna Banerjee, it showed that patients who had post-surgical DNA detection in stage 1 disease did poorly compared to the patients who had no ctDNA detectable in the blood post-surgery. And this was assessed longitudinally on the ctDNA status. So they had labs done to detect these levels at every few months after the surgery. An average of about 7.5 months was seen since the time of the surgery to the development of ctDNA positivity. And the other information that we gain is that we look at the different groups and the ctDNA positivity. The flat line is for the patients who are high risk and plus low risk, but who are ctDNA negative, and they have an excellent prognosis. But even the low risk and the high risk, if they have a ctDNA positivity, they tend to do poorly. So this suggests that in the future, DNA testing may be used as an additional biomarker to guide our treatment in the adjuvant setting. Talking about now the evolution of treatment in the metastatic endometrial CA, for the longest time, we look at the treatment backbone of paclitaxel and carboplatin, and by adding a third agent such as doxorubicin, we were not able to improve the outcome on these patients. Extrapolating from ovarian CA, bevacizumab, when added to carbo and paclitaxel, showed improvement in a small subset of patients who were P53 positive, but this was an exploratory analysis and this was a phase 2 trial. So if we combine chemotherapy with the immunotherapy, it enhances the effect of the immune response, and we are able to improve the outcomes with the improved synergistic activity of these combination. So we have three trials with chemo and IO in the metastatic setting. I will discuss the Ruby trial and the GY018 together because of the similarities. Although in the Ruby trial, it had also included patients who had high-risk disease such as carcinosarcoma. So these patients were randomized stage 3 disease, stage 4 disease as a first-line treatment with immunotherapy, dostarlimab plus carbopaclitaxel for 6 cycles, and then placed on maintenance dostarlimab for 3 years versus the chemotherapy alone arm. In the GY018 trial, similar randomization to Pembro plus chemotherapy, similar backbone for 6 cycles, followed by Pembro for 14 cycles. In both these trials, the PFS is improved in patients who have the deficient mismatch repair, as seen in terms of the progression-free survival as well as in the overall survival. And the benefit is also seen, although the magnitude of benefit is not to the same extent in patients who have the proficient mismatch repair, but the hazard ratio is 0.76, and this is statistically significant. The effect in terms of the overall survival are a little attenuated in the Pembro chemotherapy arm. This is also because the patients were allowed to cross over to the immunotherapy arm on progression. Now, if you look at the PFS benefit according to the molecular subgroup in the Ruby trial, then we see that all subgroups of the patients are benefiting in terms of the PFS. The ATTEMPT trial is a little different because it has a PD-L1 inhibitor. Here, atezolizumab was given along with chemotherapy, and the endpoint was progression-free survival in the deficient mismatch repair protein. And if the hierarchical analysis showed positivity, then the PFS in all comers was tested. The primary endpoint of PFS, as you see in the dMMR patient, is clinically significant, and this is of the same magnitude that we see in patients in the Ruby and the G1018 trial, and all these three graphs are comparable. But when we come to patients who have the proficient mismatch repair, although the Ruby and the NRG018 show benefit, the ATTEND trial does not replicate the same benefit here. So what about patients who have advanced proficient mismatch repair endometrial cancer? What can we offer to these patients? Can we improve the immune response in proficient mismatch repair with a combination of PARP inhibitor and immunotherapy? We all know that when we give PARP inhibitors, they cause synthetic lethality, which increases the tumor antigens, which causes the sting response, and then it recruits the immune response, thus augmenting the immune pathway. And so this was addressed in the DUO-E trial, in which patients who were, regardless of the mismatch repair status, were randomized to a chemotherapy arm versus chemotherapy plus durvalumab, and a chemotherapy durvalumab followed by maintenance durvalumab and olaparib arm. Now, the primary endpoint was comparison of the durva arm to the control arm, and the durva arm to the durva olaparib arm to the chemotherapy arm. There's no direct comparison of the quadruplet arm to the doublet to the triplet arm, and so the results that we have show that in the ITT population, the progression-free survival is improved in patients who have the quadruplet arm. Now, can we appreciate the benefit of we do appreciate the benefit of the quadruplet in the deficient mismatch, but in these patients, they do well regardless of the PARP inhibitor. So do we really need to give a PARP inhibitor to a patient who are mismatch repair deficient? But when we look at the mismatch repair profession, they tend to have an added advantage, which is in terms of about 6 months, 5 to 6 months gain in the progression-free survival. If one were to look at the study and look at the ctDNA clearance in the 3 arms of the chemotherapy alone versus the triplet arm versus the quadruplet arm, one sees that the DNA negativity rate clearance is greater in the quadruplet arm than the other arms. This is again similar depiction here showing that the DNA clearance is 13% with the chemotherapy, it is 17% with the immunotherapy, and it is 48% compared to the control arm in the quadruplet therapy arm, and that there is less rebound in these patients. Nonetheless, these are hypothesis generating analysis, and convincing results need to be seen in the future to use this data. What if we were to not use immunotherapy as a first-line treatment? Can we give this as a second-line treatment? And so if you have given somebody 6 cycles of chemotherapy, paclitaxel, carboplatin, and they've had some kind of response, and after that they have progression of disease, can you combine pembro and lenvatinib? And this was also attempted in the second-line treatment of endometrial CA, and what was seen is that there is a improvement in the outcome in all comers, whether you is proficient or deficient in the mismatch repair, and hence the approval was made for proficient mismatch repair patients. How about we do away with chemotherapy completely and we use immunotherapy alone in these patients? The LEAP trial was a negative trial and it did not meet its endpoint. So Lenva and Pembro was randomized against chemotherapy as a first-line treatment, but this was given in all comers. And in all comers, it did not see an impact in the PFS. The Dominica trial and the Keynote C93 are also addressing this, but they are looking at a specific population of patients which are deficient in mismatch repair. The copy number low group of patients with endometrial CA tend to have more hormone positivity, and these are the patients who respond to anti-hormonal therapy, and results have shown that there is a response in the range of 2% to about 10% by the use of megestrol acetate and fulvestrant in the
time of
ER
interest we need to just
positive
pause
subset
the
of
remaining
patients.
slides.
Learning from the endocrine therapy of medicine.
So Dr. Izmina is not with us. Unfortunately, she is away, not in Pakistan. So our next speaker is Dr. Joanne Alferi. She is an associate professor of oncology and associate chair education in the Department of Oncology at McGill University, and she served as a co-director of radiation oncology fellowship programs and assistant dean of postgraduate medical education curriculum at McGill University. So thank you, Joanne, for accepting our invitation and giving us a talk on locally advanced cervical cancer. Yeah, can you hear us, and are you online with us today? We can see you.
Yes, I can hear you. Can you hear me?
Yeah, thank you. So I'm just going to play your talk first, or you want to say something first?
Oh, it's my pleasure to be here. I guess you'll play my talk, and then I'm here to answer any questions if need be.
Yes, thank you so much. Thank you.
And I'd like to thank the organizers for inviting me to give this talk on cervical cancer. My name is Joanne Alfieri. I'm an associate professor in the Department of Oncology, and I am a radiation oncologist at the McGill University Health Center. Here are my disclosures. But more importantly, for a talk on cervical cancer, another disclosure I have is that I work at a quaternary care hospital in a resource-rich cancer center in Montreal, Canada. The cancer center is there on the left. And we're really equipped with state-of-the-art treatment in radiation oncology, including an MR sim, and we have the capacity to do image-guided interstitial brachytherapy, which I understand is not the case in every cancer center in every country. The objectives of this talk are to review new cervical cancer patient management strategies with the recent publications of the Keynote A18 and Interlace trials, and to discuss the impact and barriers of recent data in clinical practice. Here, just to show you a comparison of our countries, on the left we have Pakistan, and I'm showing here the age standardized incidence versus mortality per 100,000 women in each country. On the right-hand side, we see Canada, with an incidence that is higher and a mortality that is only slightly lower, probably reflecting our long-standing screening program here in Canada and close to 20-year history now of HPV vaccination as well. I thought I would start with a case. This is a case of Miss P. She's a 63-year-old woman who was healthy, who began having postmenopausal bleeding for the last year, and then increasing lower abdominal pain. On presentation, her physical exam showed a left-sided cervical lesion extending into the lower third of the vagina. It was necrotic and bled easily. And there was parametrial extension bilaterally, but not extending to the sidewall. Her biopsy comes back for well to moderately differentiated squamous cell carcinoma, HPV associated. She sent for a staging MRI and PET scan and found to have the local extent corresponding to the physical exam, as well as bilateral FDG avid external iliac lymph nodes, one on the right and one on the left. And her PD-L1 CPS score is greater than 80. This is her MRI. As you can see, there's a rather extensive lesion. It abuts the posterior bladder wall and is causing bullous edema, but is not frankly invading the bladder. There's extension down to the lower third of the vagina, and there's parametrial extension on both sides, more on the left than on the right. I'll now go into a discussion of the Keynote A18 trial, which was a trial, a randomized double-blind placebo-controlled trial, which looked at the addition of pembrolizumab versus placebo to standard of care. As you know, the standard therapy for locally advanced cervical cancer has not changed in the last 25 years. It is a combination of cisplatin weekly along with external beam radiotherapy, followed by a brachytherapy boost. Modern radiotherapy techniques such as IMRT, VMAT, and image-guided brachytherapy have been shown to increase local control, increase overall survival, and reduce toxicity. PD-1 inhibition with pembrolizumab was effective in the recurrent or metastatic cervical cancer setting, and therefore this study looked at adding it to primary treatment for locally advanced disease. This is a schematic of the study, and as we can see, the key eligibility criteria were based on FIGO 2014 staging. This included early stage patients 1B2 to 2B who were node positive, and patients who had stage 3 and 4A disease, whether they were node positive or negative. They stratified patients between EBRT techniques, staging at screening, and planned dose. As you can see, there was stratification for less than 70 gray to be able to include those patients treated in Japan, for which that is the standard. Those patients were randomized to standard of care, chemoradiotherapy, with or without pembrolizumab, followed by pembrolizumab maintenance or placebo for 15 cycles. What's important to note is that this trial accrued 1,000 patients very quickly over a period of 2 years. And that if we were looking at FIGO 2018 staging, the patients who are earlier stage 1B2 to 2B node positive would actually be staged as 3C1 or 2 if periodic nodes were positive today. They did include periodic node positive patients in this study. I've also highlighted here that the funder of this study participated in data analysis, data interpretation, and writing of the report. And this was done by a pharmaceutical company, and so that's important information to know. So once again, to reiterate, they used FIGO 2014 staging, where nodes were not part of the staging. They allowed periodic lymph node positive patients and lower vaginal involvement, so stage 3A patients. And these were the characteristics of the patients. Most patients had a PD-L1 CPS score of greater than 1. There were a very advanced cohort of patients with over 60% having positive pelvic lymph nodes and about 20% in each arm having positive pelvic and periodic lymph nodes. The external beam radiation was quite advanced. This was either in the form of IMRT or VMAT in 88% of patients. Here are the results. So in terms of progression-free survival, we see that there is a significant difference at 36 months in favor of the pembrolizumab arm, 64 versus 55%. And in terms of overall survival, the final analysis at 36 months, there's a significant difference in favor of the pembrolizumab arm, 82% versus 75% approximately. When we look at the forest plot on your left-hand side, what we see is that the confidence interval crosses 1 for those 1B2 to 2B patients, but is in favor of the pembrolizumab arm for the subgroup with stage 3 and 4A disease. The safety profile demonstrates that what we expect when we add immune checkpoint inhibitors to any treatment is that there are additional treatment-related adverse effects, with 60% of patients having adverse effects in the combination phase and 16% of patients having adverse effects in the monotherapy phase. So higher toxicity in the combination phase as opposed to the monotherapy phase, and higher toxicity in the pembrolizumab arm versus the placebo arm, but not clinically contrary to anything we expect clinically. As you can see in this graphic, most of the immune-mediated adverse effects were due to thyroid, either hypo or hyperthyroidism. And in terms of colitis, the pembro versus placebo arm are not very different. The conclusions of that study were that the addition of pembrolizumab to standard of care improves progression-free and overall survival, and that there was a manageable safety profile consistent with the known profiles of the individual therapies, including immune checkpoint inhibitors. That adverse events were more common during the combination therapy versus monotherapy phase and generally decreased to baseline levels after 3 months, and that this should be the new standard of care in these patients. We then have another study published around the same time frame, the GCIG Interlay study, looking at a different alternative to treating these patients, which included induction chemotherapy followed by standard of care chemoradiotherapy. This was also a phase 3 randomized study. And many of these slides are drawn from those presented by Dr. McCormack at ESGO. So I'd like to acknowledge that. These patients included FIGO stage 1B node positive patients, 1B2 up to 4A patients. However, this study did not include any patients with nodes above the bifurcation, so no periaortic lymph node disease. Also, these patients were treated with 6 cycles of carboplatin and paclitaxel for 6 weeks weekly. And then this was followed by standard chemoradiation starting week 7. If they were not treated on the experimental arm, they simply went to standard chemoradiotherapy. So just to note, these patients were staged based on FIGO 2008. This was because this study took 10 years to accrue 500 patients. So we have to understand the landscape at that time. There were no periodic lymph node positive patients allowed in the study, and no lower third of the vagina was allowed on the study either. The study accrued patients from 5 countries, most of which came from the UK and Mexico. And as you can see, a much lower risk cohort of patients in the sense that 70% approximately were FIGO stage 2B. I also wanted to point out with this graph that this was the radiotherapy that was delivered at the time, and it evolved over time in the study. But 60% of these patients received 3D conformal external beam radiotherapy, and the majority also received 2D or 3D point A brachytherapy, with only 30% of patients treated to a volume. Adverse effects from the study were as expected as well when adding a course of chemotherapy. So mostly hematological side effects, which reversed over a 12-month period. And really as expected for this profile of treatment. Here are the results. So there was a difference in progression-free survival in the induction chemotherapy arm, with 5-year results being 73% versus 64% in favor of the induction chemotherapy arm. In terms of overall survival, there was also a statistically significant difference, with an 8% increase in overall survival in favor of the induction chemotherapy arm. And what's very interesting is that these authors reported their patterns of relapse, showing a decrease in distant relapses from 20% to 12% within the induction chemotherapy arm. So now back to Ms. P. How did we treat Ms. P with the stage, with a lower vaginal involvement, so stage 3A, but then also positive pelvic lymph nodes, so stage 3C1, if we're looking at the latest FIGO staging for cervical cancer? Well, we enrolled Ms. P on the A18 study. And so she received pembrolizumab or placebo in conjunction with chemoradiation. We used EBRT VMAT planning, and this is her plan, with a simultaneous integrated boost to the gross lymph node volumes, 55 gray and 25 fractions, with the remainder of the elective areas receiving 45 gray and 25 fractions. And then this was followed by MRI-guided brachytherapy. And you can see the targets on the left-hand side there. What we see with the numbers is how her brachytherapy plan did not achieve the targets for the rectum or the rectovaginal point, most likely because we were treating the entire vagina down to the introitus. And so those are difficult to attain when treating the length of the rectum. We also attained a very good dose for the D90 HRCTV at 91 gray. We believe that this patient was on pembrolizumab treatment because at one point in her treatment, we needed to stop the study drug for pneumonitis, which resolved with a course of prednisone. And this is the result that we achieved. She is currently 3 years after this treatment, and she fortunately has no evidence of disease and is doing quite well. So in conclusion, finally, there are multiple options for locally advanced cervical cancer. I believe that interlace is a great option if there are contraindications to immune checkpoint inhibitors and or access issues to these drugs, or if there's delays in starting radiotherapy. One would be more inclined to start with upfront chemotherapy. I believe, however, that this treatment is likely more beneficial in earlier stage patients, given the cohort of patients that were treated in interlace. In terms of the A18 study, despite having a higher risk population, they had improved progression-free survival and overall survival. What we don't know, however, is if the cost of the treatment is valuable in those patients that have lower risk disease. The generalizability of that study to lower resource settings is currently limited. And we're really lacking the patterns of relapse data, which would be very nice to have, because we know that in cervical cancer, the most important goal is to decrease distant relapses. And I would like to know if that was the case in the A18. I'm sorry about that glitch. Finally, given the adverse event rates, we still don't know what the best combination, sequence, and duration of chemo and immune checkpoint inhibitors are, and this definitely requires further refinement in future studies. Thank you so much for your attention.
So thank you so much for taking us through the interlace and A18 era. I think this is one of the great challenges we are also experiencing these days, seeing bulky diseases. So except Dr. Azmina, we have Dr. Irfan and Joanne for our question and answer session. So happy to take any questions, if any.
Thank you. It was wonderful talks. I have question that in this era of pembrolizumab and the interlace trial showing benefits of induction chemotherapy, so how do we select patients? Which patients are ideal for the induction chemo and which are the ideal for the pembro combination? And what were the difference in toxicities and by adding pembro and all?
Does you want to take on the
Yeah,
question,
I
or
think
I can
she's
just go ahead?
online as well. Otherwise,
Okay.
we have you.
So it's a very important question. because nobody really knows the answer right now. So there are 3 recipes in the market. One is Interlace, the other one is Keynote, and there's a third one, which in our MDTs now we call Internote. Okay, because there are many patients who are getting now combination because there was no overlap. Interlace is neoadjuvant, and Keynote starts from radiation, goes on to the post-radiation setting. So mentally, it is very easy to just do Internote. So I think there are lots of pitfalls in both of these trials. I'm a clinical oncologist from UK, so I have a more like a global radiation chemotherapy hat, but my bias is more towards radiation. And not because of just that bias, but the slide I put in my presentation was to show that if you did a proper radiotherapy, the small benefit which existed with very costly drugs. I mean, I can go back and show you the slides of a recent publication from the Health Economics in US, where cost per quality adjusted life year, the cap is $100,000. It turns out that the Pembro program cost per quality was $180,000. So they concluded that it was not cost effective, even in the first world market. And then in our setting, we have to weigh the options. Either you are going to put a subject to pay for long-term number of pembrolizumab cycles. Of course, people outside in pharmaceutical will be very happy. But are you going to stress more on a very cheap radiotherapy, which most centers now have image-guided radiotherapy with daily CBCTs? Most centers who practice brachytherapy, they have ability to do at least CT scan to guide their, we don't do MRI scan on every session for brachytherapy. There is actually a trial in Embrace setting going on in India where CT guided brachytherapy is good enough, and we know that. So can we optimize CT guided full dose radiotherapy with simultaneous boost for external radiation, plus using VMAT or IMRT image guided, plus interstitial brachytherapy to escalate the dose, as I showed in the presentation, to 90 to 95 gray? Not many of these patients in these pharmaceutical trials actually had that benchmarked Embrace trial style radiotherapy. So we have option in this part of the world, that are we going to go for Pembro, put the patient in trouble to asking for sell their piece of land and pay for Pembro for that 5%, or are we going to optimize the cheap radiation which they're going to have it anyway? That is our option. So in my opinion, in this part of the world especially, if we have 3 scenarios we can put effort: fully optimize external radiation with brachytherapy, interlace with platinum and the given before, Keynote with heavy duty Pembro. So I will take in this sequence. I will fully optimize the external radiation with fully optimized brachytherapy. Number 1 choice. Number 2 choice, if I have a patient who has a very large tumor, which again, we had been doing upfront chemoradiation in those patients with stage 3B, 4 patient, 10 centimeter big melon sitting there. We have been doing chemoradiations. We have tried Outback trial, which is adjuvant chemotherapy trial, failed. But again, the problem was that every patient had box radiation. So in my opinion, majority of our patients, we can get away with simple concomitant chemoradiation with fully optimized, simultaneously boosted external radiation, plus image-guided adaptive brachytherapy using needles in more than 90% of our patients, achieving the table I showed you in the benchmark, 90 gray plus to the EQD2 to the HRCTV. All right. We should optimize that. There are some patients where there are big melons. You want to shrink that just for the geometrical sensibility part. You can give them Taxol carbo before to maybe shrink them, although it gives me trouble for external radiation part because their lymphopenias and thrombocytopenias and anemias can be a trouble. I personally do not use pembrolizumab very often because, again, I do not believe that really translates. Although my medical oncology colleagues, when they see a patient, they will put everybody on Keynote 18 trial. However, you must select a patient appropriately who has got a good, the scoring PDL score and really periodic nodes and all over the systemic disease kind of scenario. Then maybe yes. So periodic nodes immediately out from interlace. For radiation, extended field, periodic, systemic disease, yes. Keynote, possible systemic recurrence, yes. So periodic disease patient, definitely I will consider Keynote 18. Very high iliac disease patient with very poorly differentiation, very large tumor, very high risk of systemic relapse, I will use Keynote 18. But majority of my patients with just bulky tumors, I will just go either with optimized, fully optimized, put all my effort and optimization of radiotherapy. This is why I wish there was a full session of how to optimize the radiation. Cervix cancer, local radiotherapy fully optimized does wonders and reduce the benefit, relative benefit of all these expensive drugs, expensive toxicities, 6 to 10 times higher toxicity compared to chemoradiation in Keynote in most of the scenarios. Even if it is hypothyroidism, who likes it? And even the risk of colitis or whatever. So this is how I will go. Majority of my patients will get concomitant, fully optimized radiation. I will sweat everything on it to optimize my external radiation with simultaneous boost, at least 60 gray to the gross lymph node. And followed by fully optimized image-guided brachytherapy using needles and using at least CT scan and give 90 gray plus. And then I select some patients with bulky tumor. I want to shrink them with interlace or a very large periodic, high risk of systemic release, pick for Keynote 18. But bulk is concomitant chemoradiation, fully optimized. Yeah.
Anything you want to add, Joanne? It's a question from you as well after you.
Can you hear my?
Yeah.
Do you have my sound?
Yeah, we can.
Yes.
Okay, I agree with Dr. Irfan's approach. I think we need to. So in Canada, it's pretty easy. Health Canada has approved pembrolizumab only for those patients, because you saw the forest plot. So only for those patients which stage 2014 stage 3 and 4 disease. We actually cannot use pembrolizumab. It's not approved for those patients with stage 1B and 2 disease, even if they're node positive. However, I think it's important to point out that in the A18 study, the external beam and the brachytherapy was extremely high quality. So it was done, I think, between 2020 and 2022. And it was majority of the centers using image-guided brachytherapy and VMAT. So I think in interlace, we can talk about compensation for perhaps lower quality, poor quality external beam and brachytherapy with the chemotherapy. But in the A18 study, I'm not sure we can argue that. Although I fully agree with optimizing the external beam and the brachytherapy first. We have seen quite dramatic responses with advanced tumors with pembrolizumab. So that is who we favor it for.
Yeah. Any other question? We have a couple of online questions as well. So one of the online question is, I think it's from both of you. In the era of the interlace trial, if there is a complete response to and there is no residual disease, so how you are going to contour your low risk CTV for brachytherapy?
Okay. So it's a good question, because there are patients actually we do see that there is nothing on the MRI scan after finishing the protocol for interlace neoadjuvant part. For them, the protocol is exactly what we do in Embrace trial, which is basically just HRCTV is supposed to be the whole cervix. So having no disease on MRI scan does not mean there is no disease. So you will still go ahead with the full program as you will. However, in future, possibly with Embrace low risk or high risk protocols, we will be possibly individualizing or dose de-escalating these patients. But currently, as it stands, you will just offer still a standard program of chemoradiation, brachytherapy, and HRCTV for part of brachytherapy is going to be the same thing, which is by definition the full cervix plus a residual tumor, which in this case it's none. So full cervix. That's in my opinion.
Yeah. So the other question is,
Can I just add to that answer just for a
yes, sure.
second?
Yes, sure.
I think it is a very challenging question. Actually, the few patients we treated on the interlace protocol, this was actually the challenge, is to know what volume we're going to use now that it's shrunk down to a normal looking cervix, which is quite dramatic after 6 cycles of chemotherapy. So what I find the most challenging is actually at brachytherapy. So your low risk CTV and external beam is actually including the parametrium and usually including the areas that were included before, that were involved before, excuse me. I might extend to the bladder wall if that was involved, because we just don't know whether we can exclude it after the tumor has shrunk down. But what I find challenging is in brachytherapy, where as perhaps before interlace, we would have used interstitial catheters to cover extensive disease. Now everything is looking normal, and we don't know if we can get away with just intracavitary brachytherapy alone. I mean, you would think you would cover the cervix and that's it. But since those areas of the parametrium were involved before, I don't think we have the answers yet on whether we can ignore them after neoadjuvant chemo.
Yeah.
Just to add
yeah.
one more thing on this one is that the question which was just like the comment which is like a low volume or no volume cervix tumor, the role of needles. I think that is a very important point in itself. Although here in this part of the world, we don't encounter that frequently because we have large tumors. So even if you do interlace, you will still have a large tumor. So that's not an issue. But in patients who have no tumor or very low tumor, there are options, of course, just to give intracavitary. Although my personal preference is to still stick some needles. And for that, to force myself, I use Auris applicator, because Auris applicator has a dead ring. It just requires needles to be placed all around. So the benefit I see, which I call, is a squashed pier, which means that you don't have to blow the dose into the bladder or rectum, even if you are meeting a constraint. Constraint does not mean that dose is ultra safe. The best dose of radiation is safe is 0 dose. So if I can have a strategy very simply to squash my pier from anterior posterior, lower down any pixels of bladder and rectum in the favor of going into the laterals, I will use that. So in my personal practice, almost all patients, I mean, Embrace 2 was 74% patients, although in our centers we aimed for 80%. But rarely there are patients where we do have a scenario where we don't put the needles, just not only for the tumor part, but for the organs at risk part.
Yeah. And how frequent actually you see cervical fibrosis in those patients? And sometimes we do see PET avidity post-treatment in these particular patients who have a complete response and we have given the full dose. So how you deal with that?
Yeah, it's an extremely important point you just highlighted, because this is the subject of my current interest. And that is, I coined a term called RAC, radiation-associated chronic cervicitis. So what happens is that because of dose escalations, you want to give a very high dose to HRCTV, which means that if you are not putting needles, you are dragging the dose volumes in this direction. And where are you drawing the dose from is from the central tendon. And the central tendon is sticking at the surface of the cervix. So when the point A was there, then we know that what dose the cervix surface will get. However, if you are trying to be smart and you are trying to pull the dose away to the parametrium area and using only the central tendon, if you look closely at, say, 3 millimeter depth of the cervix surface, you are giving nearly 200 to 300% dose. And that really means that the surface of the cervix is going to have a necrosis, chronic inflammation. Patients, if you watch them closely to kind of look for survivorship issues, one of the things they will tell you that there is a discharge, which we usually shrug our shoulders and ignore it. But that discharge, we caused it, and that is what you just said, Pat, highlighting some chronic inflammation. Do we really need to do that? And that is the reason that I put needles, because the needles will just flare the dose here and there and cool down the central tendon. Currently, in Embrace, we are only cooling down the vaginal loading. But I think the next point in future, which I spoke already to Professor Potter, is that we must look at the cervix dose at 5 millimeter. Because this chronic cervicitis is going to become more issue when the dose is going higher and the people are not putting needles, then you are going to be encountering this issue more and more.
Excuse me. We do face, we have stage 3 and stage 4 cervical cancer in our part of world, in society, in our country. We usually very rarely have early stage disease, cervical disease. Okay? And many times we do receive patients with rectovaginal fistula and vesicovaginal fistula, and these are the rare problems. So is it a part of our, you can say that lack of strategy, or something we are lacking in the advanced radiotherapy technique, or how we can overcome it?
Yeah, I think it's a very, very important question, because as our Canadian colleague highlighted, that they see a lot of patients, but a lot of patients are diagnosed through the public health screening. So in UK, for example, it's a call and recall system for the pap smears. Unfortunately, in Pakistan, we do not have primary healthcare integrated system. We do not have a public health screening program. Hence, there is no early catch. And on top of that, there is no vaccination programs. So unfortunately, most patients are going to present with symptomatic disease rather than a pap smear detected early cervix cancer. So we are encountering this in this part of the world. We are not the only one. In all countries in Asian population, in India, in Sri Lanka, everywhere, the same story. Any country where there is no public health screening program, there is no vaccination program, there is no public educational program, there are cultural issues for women to present with vaginal symptoms. This is the classical presentation for a cervix cancer. And on top of that, unfortunately, our part of the world has higher risk and higher rate of cervix cancer anyway, for some reason, for HPV or whatever. So as a radiation oncologist, we are on the other side of the receiving end, where we are just thrown a challenge to say, okay, how do you deal with this one? Right? I wish that we are not given those challenges, and we are given better cases, looking cases like our Canadian colleagues, or we deal in UK, where we are trying to think about scratching our head for dose de-escalation. Here we have to always think about dose escalation. And that is unfortunately because of lack of public education, health screening programs, and the vaccination programs.
And the other tragic part of the story is that many times the women, they do have all the symptoms and they report to the general surgeon.
Yep.
And they do subtotal hysterectomies, and the patient come to us with huge cauliflower like big vaginal growth. So where you have problem for the brachytherapy as well. How do you plan all this?
Yep. So we are
and all this.
Yeah, we are sitting in this room talking about the high-tech stuff.
Yes.
We're talking about the interstitial, image-based, Pembro, all kind of stuff. But our real problem is exactly what you're highlighting. Not only when I said lack of public education, we have a lack of secondary care education as well. And then, of course, we know our place, that there are some, the financial incentives and, the egoistic practices and all kind of stuff. So unfortunately, we must continue to educate our youngsters about the ethical practices, about the specialist-driven practices, about even not the surgeon and the cervix cancer, general surgeon and cervix cancer, not even that, gynae versus gynae oncology. So we should continue to educate to our secondary care, We should continue to educate our primary care. We should continue to educate our public education. I think education slowly will infiltrate into the masses, and then we will start seeing the fruit of what we will continue to struggle. And these type of meetings will continue to also lead to this publication everywhere in the media that look cervix cancer and this kind of stuff.
My
Yeah.
question is, how do you treat such patients with a cauliflower-like growth and you don't have anything to put inside?
Yep.
But how do you treat? How do you give
So,
radiation therapy?
If I just sum up, because in interest of time,
Yeah.
I would like to conclude the session, but Dr. Rubina, I would like to say yes. In this era, we also see sometime experience, and this is the real world scenario. So with the help of chemotherapy, we tend to downstage these patients and then try to put our brachytherapy instrument in and to give the full dose. So thank you everyone, and thank you Jane for keeping you up so long, and really appreciate that. Thank you Dr. Irfan, Dr. Azmina, everyone for the wonderful talks.
Thank you.
you.
It's my pleasure. Thank you.
Thank you.